Good afternoon, everyone. Welcome back. I hope everyone had a good lunch. I'm Dr. Kathleen Monahan, and today it's my great pleasure to introduce Steffi Bechelet. Steffi, forgive me if I'm mispronouncing your name. I'm sure you can correct me. But Steffi is a domestic abuse and brain injury researcher in the social change and policy team at Brainkind. She holds a BA in International Relations and Security Studies from the University of Bradford and an MA in Gender, Violence, and Conflict from the University of Sussex. She co-led the groundbreaking study, Too Many to Count, the first United Kingdom research exploring the prevalence of brain injury among domestic violence survivors accessing community-based services. As part of Brainkind's next steps, Steffi has led the development and pilot launch of Brainkind Adapt, a digital resource designed for professionals in domestic abuse services. Without further delay, I will let Stephanie present From Research to Resources, Raising Awareness of Brain Injury Symptoms in Survivors Accessing Domestic Abuse Services in the United Kingdom.
Thank you so much, Kathy. That was a lovely introduction. I'm just going to attempt to share my screen. Welcome, everyone, and thank you so much for joining me for this presentation. I appreciate for some of you it's the afternoon, for some of you it's the evening, if you're this side of the pond, and for some people it's the morning. But regardless of where you are, thank you so much for joining. As Kathy's just introduced me, I'm Steffi Bechelet, and I'm the Domestic Abuse and Brain Injury Researcher at Brainkind. And today I'll be sharing our journey from research to resources, raising awareness of brain injury symptoms in survivors accessing domestic abuse services in the UK. So a little bit about Brainkind. Brainkind is the largest national charity supporting people with brain injuries and other neurological conditions in the UK. We have over 40 years experience and we are committed to providing personalised and compassionate treatment and care. We're led by a team of clinical experts, and our services include a holistic approach to rehabilitation, focusing on physical, cognitive, and vocational rehabilitation, alongside educational and emotional support, designed to empower the people we support and their families. We use our experience with brain injuries to help shape government policies here in the UK, change perceptions, and improve lives. We also conduct research that helps identify unrecognised areas of need and contributes to developing and improving services and interventions. At Brainkind, we think that everyone with a brain injury, regardless of their circumstances, should have equal and easy access to the right services. And I just want to give a little bit of a context of how things differ in the UK in terms of definitions. So the UK government defines domestic abuse as any incident or pattern of incidents of controlling, coercive, threatening behaviour, violence or abuse between those aged 16 or over who are personally connected or have been. And this includes intimate partners or family members and is regardless of gender or sexuality. And this abuse may involve one or more of the following types of abuse. So it's not just limited to physical violence, but also includes sexual violence, economic abuse, psychological and emotional abuse, violent or threatening behaviour, and controlling or coercive behaviour. So it's a very broad definition. And just to situate that, with the prevalence of domestic abuse in the UK. In the year ending March 2024, the Crime Survey for England and Wales estimated that 2.3 million people aged 16 and over had experienced domestic abuse. That the police had recorded over 850,000 domestic abuse related crimes in England and Wales during that same period. And this equates to a call to the police about domestic abuse roughly every 30 seconds, making it one of the highest volume priority crimes in the UK. And domestic abuse is often referred to as a hidden crime, one that's not always reported to the police or frontline services for various reasons. And therefore, data can only provide us with a partial picture of the actual levels and types of domestic abuse experienced, and the real numbers of incidents are likely to be far higher. And research shows us that disproportionately women are impacted by domestic abuse, but there are further disproportional impacts to people from minoritised groups, many of whom are already facing multiple disadvantages. And this includes older people, people already living with a disability, people from minoritized backgrounds, depending on their immigration and their race, and people who are from the LGBTQIA+ community. So where does brain injury come in? So domestic abuse, as I'm sure many of you on the call are aware, is one of the top causes of acquired brain injury in women around the world. And again, I mention this about women because we know that domestic abuse is an overwhelmingly gendered and sex-based crime that is deeply rooted in societal inequality between men and women. But we also acknowledge that anyone can be a victim or a survivor of domestic abuse. But the connection with potential brain injury comes in with the high prevalence of head, neck, and face injuries that unfortunately are incredibly common when someone experiences physical violence. And global research, led by many of the people on this call, indicates that the number of these incidents that involve hits to the head range between 40 to 92%, with nearly half of the survivors across these studies also reporting experiences of strangulation. These findings demonstrate that domestic abuse survivors are at an increased risk of experiencing both traumatic and hypoxic brain injuries. We also know that women often present with different symptoms to men, and this can potentially lead to a misattribution of symptoms. And I'll get onto symptoms a little bit later. But we know that people who have experienced domestic abuse are more likely to experience a brain injury that might present as a hidden disability, that there's an increasing awareness that even those brain injuries that might be classified as mild, and I appreciate there's some move away from that term, but even mild injuries can have long-term cognitive, social, and emotional consequences that require support across someone's lifespan and not just the acute phase of someone's injury. And data also tells us that the risks and impacts of injury increase if you experience more than one injury, of which unfortunately is often the case for people who have experienced domestic abuse. And data in the UK suggests that on average, survivors experience upwards of 50 incidents of abuse across many years for many survivors before they get effective help. And we know that there are significant barriers to accessing brain injury rehabilitation in the community, and that without access to the right brain injury support, you are likely to experience an increased financial vulnerability as well as social isolation. And we know that both of these are risk factors for domestic abuse. So I just want to set the scene for Brainkind as an organisation and the journey that we've been on in terms of understanding the connection of brain injury and domestic abuse and the potential prevalence in the UK. So Brainkind has proudly been at the forefront of investigating this link between brain injury and domestic abuse since its landmark report, shown here as Making the Link, in 2018. So from 2016 to 2018, in the first pilot study of its kind in the UK, we provided a dedicated service to supporting and identifying and rehabilitating women with a history of brain injury in HMP Drakehall, which is a prison in England for women. The report that revealed that 64% of these women screened positive using the Brain Injury Screening Index for a history suggestive of brain injury, and of those women, more than 60% attributed that to their experiences of domestic abuse. And this became the starting point of Brainkind's work, focusing on linking experiences of domestic abuse and the potential prevalence of brain injury. And then in 2019, Brainkind convened an expert roundtable to explore the implications of brain injury in domestic abuse contexts. And this saw a panel of experts, including academics and representatives from leading domestic abuse charities, as well as National Health Service England, come together to discuss the needs of survivors who have experienced domestic abuse and who may be living with a brain injury. And the resulting publication, An Invisible Impact, highlighted significant gaps in awareness, training, and policy for professionals. So Brainkind then conducted a national audit in partnership with Safe Lives, a leading national UK domestic abuse organisation, with the findings shared in a practitioner's perception. And this revealed that 81% of practitioners we spoke with had no training in brain injuries, and more than half felt unprepared to identify symptoms of brain injuries, really reinforcing the need here for further research to understand the prevalence of brain injury amongst survivors accessing domestic abuse services. And this led us to Too Many to Count. And it's our fourth report developing recognition of the importance of brain injury in the context of domestic abuse. It was the first study of its kind in the United Kingdom to explore the prevalence of a potential brain injury in people who have experienced domestic abuse who were accessing domestic abuse services based in the community. And data collection began in 2022 and took over just took just over a year to undertake all these interviews with 60 survivors across 9 different host sites. And these were domestic abuse services across England and Wales. Some were refuges, some were community outreach services. We had an age range of participants from 18 to 72, and the sex and gender of all the participants in this study, for people who felt ready to talk to us, happened to be female and women. But as I said before, we identify that anyone can be a survivor of domestic abuse. And in this study, we used 7 different measures, and we screened for a history indicative of potential brain injury, post-concussion symptoms, depression and low mood, anxiety, anger, and post-traumatic stress symptoms. And this is what we found. 1 in 2 people that we spoke to, so half of all survivors, screened positive for a history indicative of a brain injury on the Brain Injury Screening Index. 80% of the women in the study reported at least 1 serious blow to the head. And I just want to share some quotes from survivors as we go through this study. So this quote from a survivor about the amount of times that she had been hit in the head, and she couldn't recall, unfortunately was a universal thread across many of the people that we spoke to in terms of an experience. And it ended up becoming the title of our report because it really summed up the complexity and the difficulty of this situation for so many people. And we also asked people if they had been held in a way that they felt they couldn't breathe, so exploring non-fatal strangulation and suffocation. And 75% of people said on at least 1 occasion they had experienced this, with 46% of people using the word strangulation to define their experience. And again, this is a quote from one of our survivors who did get diagnosed with a brain injury after seeking medical support, and was sort of reflecting upon those experiences where she was strangled to the point of losing control of her bladder. And she had always thought that that was because she was scared. And it was only after seeking that medical advice that she realized it was because she was dying. Her brain was being denied oxygen. And unfortunately, again, not uncommon for the survivors that we spoke with. And 70% of people that we spoke with also reported memory difficulties. And here's a quote from another survivor saying that they needed to go to the doctor regarding their memory because they can forget what happened an hour ago sometimes. They noticed that they kept forgetting things and they needed to write things down to make sure they didn't forget. And 63% of people we spoke to had trouble concentrating, and 33% experienced speech challenges. And we found that the women who screened positive for a history indicative of brain injury were more likely to experience moderate to severe post-concussion symptoms, low mood, and post-traumatic stress. And they also consistently reported a range of cognitive, emotional, and physical symptoms of brain injury. So I'm just going to try and hope that the technical gremlins aren't against me to show you a clip from a national media campaign that we recently ran with a national news force here, featuring a survivor sharing her experience. And we think it's a really powerful reminder of the real life impact of brain injury in domestic abuse contexts.
Michaela, which isn't her real name, is a victim of domestic abuse. She's worried the violence she suffered has left her with a brain injury.
He'd got a household object in his hand at the time, and I just remember him screaming and shouting at me. And then I kind of saw this item coming towards my head, and I felt for a second a pain to my head. Nobody has ever mentioned to me about my head injury. I do have really bad dizzy spells. I get blurred eyes quite a lot. If I touch parts of my head, it's still sore. I've also had really bad mood swings since then, and my memory is absolutely shocking.
So, of course, not every head injury will result in a brain injury. And some of the symptoms spoken about in this clip can also definitely be related to trauma and mental health connected to experiences of abuse. But I wanted to share that because I think it's a really powerful clip. And on this next slide that I'm going to show you, I hope it will explain why brain injury needs to be considered for people who have experienced physical abuse to the head, neck, and face, especially those who have a history of prolonged and cumulative experiences of violence. So this Venn diagram highlights the complexity of symptomatic expression for individuals who may have depression, may be living with a brain injury, and experiencing post-traumatic stress. And as you can see in the middle, there's quite a lot of overlap with some very common symptoms for people who have experienced domestic abuse. The majority of women in our study endorsed moderate to severe anxiety, low mood, and post-traumatic stress symptoms. And the majority of women in our study also reported cognitive symptoms, so memories with problems with their memory, slowed information processing, and difficulty concentrating. And the complexity of symptoms here and the experiences suggest that some interventions and support put in place might not be meeting the needs of individuals if brain injury isn't considered as a health outcome after physical abuse. So, based on our findings, we developed some recommendations in our report to work with survivors of domestic abuse to develop tools and resources that will enable individuals to advocate for themselves and communicate their needs clearly, to develop a brain injury and domestic abuse toolkit for domestic abuse practitioners and staff, including a quick guide to support. We knew we wanted to create change beyond a report on a shelf. So that led to us turning data into dialogue. Brainkind hosted 2 participant focus groups drawn from the 60 research participants from our study, one in person and one online. And this was to discuss the findings from the study. The groups that we met with considered the 4 key emerging themes from our report, as well as our recommendations for the next steps that I've just shown you. When we asked what they felt was needed from services to best support people and what positive changes this research could create, participants said to us, to have access to easy to understand and clear information about brain injury would enable people to self-advocate. That there is a need for consistency in support when people are accessing services and treatments, and as such, training for professionals is needed to better understand the connections between domestic abuse and brain injury. And that it's important for people to feel not only heard, but understood and supported when disclosing and seeking help regarding domestic abuse. Participants spoke about the importance of raising awareness of brain injury amongst people who had experienced domestic abuse. And one of the women stated that she thought she had had dementia or that she was going through the menopause before it was identified for her that she had experienced a brain injury. All of the women that we spoke with agreed that being provided with information that allows you to advocate for yourself is key to regaining control over your life. And women spoke about being able to access resources to understand more about brain injury and the symptoms they might be experiencing, alongside information about how to get support from a GP, a general practitioner, or any other specialist service. And the women taking part in these focus groups also talked about how important the timing of support was and how allowing that person ownership over when and how they sought support was also essential. Women who participated in the focus groups recommended to us that any tools or screening methods that we developed would need to consider the significant concerns that people have regarding access and the potential for deliberate misuse of their personal details, and that an anonymous resource or tool would be preferred by survivors seeking advice and support. And participants also told us that they were worried about how a brain injury diagnosis, if listed on medical records, could be information that's requested and made known to family courts, civil and criminal courts, and could potentially be weaponized against them. And this really reinforced to us that any tool we create for this space needs to be non-diagnostic. And we also then hosted a professional roundtable. And this event was attended by representatives from leading domestic abuse charities across the UK, including several of the host sites that participated in our study, and professionals from brain injury organisations, housing and homelessness prevention staff, barristers, and again, representatives from NHS England. The roundtable breakout sessions identified the following as potential ways that we could integrate these results into practice and achieve some next steps. So the development of a brain injury screening and information toolbox to be made available to professionals and people experiencing domestic abuse. To consider whether information could be provided online to help people identify if they needed any further assessment. And the importance of providing support after screening. So Brainkind's research, focus groups and roundtable events have all highlighted a limited awareness and a lack of resources related to acquired brain injury for professionals and people who have experienced domestic abuse. And their message was clear. There is a gap in knowledge and resources. Survivors told us they wanted tools that were trauma-informed, confidential and non-diagnostic. Professionals asked for something practical to help them feel confident in recognising symptoms and tips for adapting their support. So, we set out to try and do just that, and we've built Brainkind Adapt. And across the past year, we've been drafting this web-based tool built on feedback and used testing from professionals working in specialist domestic abuse services. But what did we want this resource to achieve? We wanted it to enable practitioners to identify symptoms of brain injury in survivors of domestic abuse, to enhance awareness and understanding of brain injury within the context of domestic abuse amongst practitioners, and to create ultimately a resource that could support a wide range of practitioners to have positive and non-diagnostic conversations around the potential impact of brain injury due to these personal experiences. A tool that supports the start of a conversation, is awareness raising, is the first step of identification, and helps facilitate further discussion around adaptation of support to meet needs. So, in order for us to do this, in order for us to consider creating this resource, we looked at what tools and resources already existed that could be used in non-clinical spaces, what tools were validated, what was the language that they were using, and what symptoms were cited frequently across our work from survivors. So the first tool that we considered was the Brain Injury Screening Index, also known as the BISI, that you can see here on your screen. The BISI is an 11-question screening tool developed by Brainkind to help identify people with a history indicative of a brain injury. It's a validated tool that can be used within prison, probation, community, and rehabilitation settings. It was used across our previous cited works that I mentioned and asked questions around blows to the head, any treatment received, any previous medical history relating to illnesses of the brain, as well as losses of consciousness. The BISI itself is not a diagnostic tool, but records an individual's self-reported history of brain injury. And when we use this in our research, Too Many to Count, we also ask participants about being held in a way that they felt they couldn't breathe, to also capture information about non-fatal strangulation and suffocation. The next tool that we looked at was the Rivermead Post-Concussion Symptoms Questionnaire. And as many people on the call know, this is used to assess ABI symptomology. Each item in this tool is scored on a scale from 0 to 4, where lowest scores represent no to mild symptoms, and it measures symptoms that have a greater impact on participation and lifestyle post-head injury. And in our study, Too Many to Count, more than 65% of women reported moderate to severe post-injury symptoms using this tool. And then the third resource we looked at, and arguably one of the most influential, was the chats, created by the Ohio Domestic Violence Network. And this is a structured questionnaire designed to support practitioners to identify and provide information on a head injury to people who've experienced domestic abuse. And we use this in Too Many to Count to also screen for symptoms in our participants. And a great part of this tool is that it includes an accommodation booklet for professionals to use and refer to when supporting individuals. So we decided as a team that we essentially wanted to build a combination of these great tools. We knew that we didn't want to create something to be used in the immediate aftermath of a violent incident, and we didn't want to replace any process about seeking immediate medical support. We knew that we didn't want the resource to be something scoreable, especially because of the complexity of symptoms for survivors of domestic abuse. We knew it needed to be non-diagnostic. But we felt that a guidance booklet, like in the chats, would really support professionals and would be a much needed accompanying resource. We knew that we wanted to create a tool that could be used when survivors felt ready to talk about their symptoms. So we worked to compile and cross-reference symptoms from across these tools to get a broad spread of categories. We had conversations about language. We knew we needed to carefully consider our wording we used and decided to focus more on symptom-based, like depression, versus more experience-based, like feeling depressed. And we knew we needed to make it consistent throughout. We wanted to ensure that we covered what our research told us were the main issues for this cohort and what survivors told us they were struggling with the most. And also the expertise of our clinical team, led by our consultant clinical neuropsychologist, Dr. Anne-Marie Burns, and our team collectively having over 30 years experience in delivering neuro rehab. We also thought long and hard about the tool accessibility. Would people be able to translate it, the layout, and of course, any safeguarding concerns we needed to consider. So we set out to make our first draft. Now don't panic. This was our very first draft of what the online tool could look like. And yes, we know, don't worry, we got rid of the lime green. But with this first draft ready, we set out to capture the views and experiences of professionals working across the domestic abuse sector. We interviewed 11 support workers from 8 domestic abuse services about their experience leading support with survivors. We asked them about their understanding of brain injury as a potential consequence of domestic abuse and how we could bring more awareness to this issue. So the professionals were all shown the draft web tool, and they were asked for their feedback for each question, as well as advice as to where to best place this tool in a survivor's journey. They told us that the tool would be best used once a survivor has built up trust and rapport with a professional, once they're familiar with the service. They also told us that the colour scheme and the layout had to change. All the interviewees said that they would use the tool with their clients, and they were really enthusiastic about the research, and many professed an interest in taking part in the next steps of a pilot. So we listened to their feedback and we began to make some changes. And in the interest of time, I think I'm just going to skip through the quotes, and I will share these slides later because I appreciate I've only got a few minutes left. But we had some really lovely and complimentary comments from people about wanting to use the tool, feeling like it was the right sort of resource for them. So, based on feedback, we amended the tool user interface, the color scheme, and the layout. We amended symptom exploration and how it was presented, and I'll show you that now, because we decided that one long list would be too overwhelming visually. But also, if someone, a survivor, using this tool with a professional said yes to a lot of symptoms, that's a lot of information to consider on one page, especially if the language feels unfamiliar to that person. So we decided on having three shorter categories as opposed to this long list, and broke them down into categories of physical health, mental and emotional health, and cognition changes. We also thought it would be best to separate the categories of symptoms from the page where someone picks the top 3 symptoms they're struggling the most with. We also then amended our draft guide for professional in response to these changes and ensured that the top 3 symptoms, as well as all the symptoms picked by the survivor, were highlighted on an anonymous summarized PDF that could be printed out with the support of a professional and used by that survivor to start a conversation about brain injury and domestic abuse with a medical professional they trust without having to remember everything. We also worked really closely with the Ohio Domestic Violence Network and Rachel Ramirez and Dr. Juliana Nemeth, so thank you so much for all your help, to develop this guidance booklet to create a resource for professionals. And we adapted their accommodations booklet to fit the symptoms listed in our tool. We amended the language and made the context fit for a UK setting. This process let us be clear about what we wanted to include in the final tool. We wanted to include 4 screening questions from the Brain Injury Screening Index, focusing on hits to the head, being held in a way that people felt they couldn't breathe, so identifying those potential mechanisms of brain injury, any losses of consciousness associated with these injuries, and any previously diagnosed known brain illnesses. We also wanted an exploration of symptoms that survivors might be experiencing, a personalised summary of responses for the survivor to take to their GP, and a guidance booklet for professionals to adapt their support. We then knew we needed to test this with professionals before launching it. So it happened very recently this year in the summer. We were supported by 30 practitioners from 9 different specialist domestic abuse services across England, including a specialist LGBT+ service, to pilot Brainkind Adapt. During this 3-month period, we collected feedback from professionals before and after using the tool and conducted calls with members of staff from each service to gather in-depth detail about their understanding of brain injury as a potential consequence of domestic abuse, and if that changed after using the tool. We asked them how the tool was used, how professionals felt using the tool with people they were supporting, and any concerns of using a resource like this in their service delivery, and any changes they'd like to see. And throughout this pilot, we made sure that the guidebook was made available to staff on the landing page of the tool, but also upon completion of the tool, to make sure that the staff could access resources and gain learning, even if the people they were supporting in their services weren't ready to use the tool. And I think I'm doing all right for time, so I will show you a couple of the quotes from the services that use this tool in the pilot. So one service said, "It's improved my knowledge and ability to talk about this subject with clients." Another said, "This is a really useful tool to help support survivors who may have suffered a brain injury. It enables safe, supportive, and structured conversations and gives practical advice on how to adapt practice as well as signposting." Another service said it enabled them to have structured, safe, and supportive conversations with their clients one-to-one, with tools to signpost and gain more understanding and information to increase their professional confidence. Another service provider said they think that they're always concerned around areas that they don't feel like they're an expert in. However, they felt that this tool had helped them be able to have those conversations, and that's exactly what we were after. And then a final quote, we have been proud to work with Brainkind in the development of the innovative ADAPT tool to raise awareness of brain injury in survivors of domestic abuse. This incredible toolkit enables practitioners to have constructive conversations with survivors, to ensure they're aware of symptoms and potential consequences, and to support them to seek more timely specialist support. And we're pleased to announce that Brainkind Adapt launched this week. Brainkind Adapt will support structured conversations about brain injury and provide guidance for professionals to adapt their approach. The tool is available on our Brainkind website for free without the need to register to access this. It's been designed for anyone working with survivors of domestic abuse, not just the domestic abuse sector. And we really see it as an important step forward in recognising and responding to brain injury in the context of domestic abuse. Thank you so much for your time today. I appreciate post-lunch. It can be a little bit difficult to get back into the swing of things. But if you've got any questions, comments, queries, obviously I'll be around for a little bit now, but please do take down my email and get in contact. And thank you so much.
Steffi, just such amazing, amazing work. I applaud you. It's just fantastic, and it brings our field so forward. It's just a wonderful, wonderful thing to see. I did
Thank you.
receive a question, which was, how can this tool, all of these tools, be used with an unhoused population who may not be able to return from multiple visits?
Yeah, that's an excellent question. So we design Brainkind Adapts to be completed in around 20 to 30 minutes. So for individuals who might not have fixed housing but might be engaging with a support service on that journey, they will be able to use this tool in whatever safe environment they work in with those people to understand brain injury and create that support. We acknowledge, it's not a perfect fix, and there will always be systems and services that might need further adaptations, but we've worked really closely with specialists across the board to try and understand all the different situations where domestic abuse might occur, where there may be physical violence and there may be potential brain injury. So that's why we've designed it to be a short tool, a non-diagnostic one, and a conversation starter.
I think that shines through in everything that you've presented today. The data that you've collected, inquiring on so many different levels of people who are working and actually experiencing the problem, gives voice to a multitude of different people that are impacted by this. And again, I thank you so much for your work. Thank you for bringing our field
Thank you.
forward.
Thank you. And that's something we've been really mindful of, being the brain injury experts in this space and not having all the pieces of the puzzle, really focusing on multi-agency collaboration, listening to survivors and what they want and what they need. Because, we could easily just publish the research, pop it on a shelf, and then go, oh, we've done that. It's fine. We've asked the question. We know the numbers. But that doesn't create change. That doesn't help people when they need it. So really, really just grateful for all the professionals and all the survivors that have given us so much time on this journey to make sure that we're creating something that will be useful, but also continuing that conversation. As I say, this isn't the end point for us. And just to talk around data collection, I didn't pop it on the slides, but we've collaborated with another major national domestic abuse charity to get questions about brain injury on their database that gets upwards of 50,000 unique data sets each year. So, this time next year, we're hoping we will have that first analysis of that data to understand the experiences of people in the UK on an even greater scale. So always looking to do more, to have more learning, and to create more change where we can.
It's just phenomenal work. And I have to say, I really loved your heading data into dialogue, because that really says it all. If we just do the research and it sits on a shelf, as you said, what good does it do? So hearing the voices of the women that experience this trauma, and then hearing the boots on the ground, the professionals who have to interact, is just a phenomenal work that you're doing. So again,
Thank you.
thank